The first airway we're going to consider if we're unable to bag mask ventilate a sedated patient would be the supraglottic airway. The original LMA versus what we use in our office, which is the iGel. You see that the original LMA is a little bit broader, has a little bit more of a point at the end. The laryngeal mask airway has to be inflated, and about 10 cc's to inflate this cuff. Issues, the laryngeal mask airway, and specifically the tip, can occlude the airway. It can move both caudal and anterior, so sometimes it'll compress on the epiglottis. The patients can compress and bite down on the actual tube, thereby preventing ventilation, and there's no way to decompress the stomach. There's no inlet to pass a suction tube to decompress the stomach. An easier intervention as a supraglottic airway is the iGel. It's made of a thermoplastic elastomer. It's very tough. You can lube this. It'll insert very easy. You do not need to use direct laryngoscopy. You do not need to inflate the cuff. There is a bite block that prevents patients from biting down and actually occluding the tube, and there's a little port that you can use to insert a suction and decompress the stomach. Let's take a peek at how we would insert the iGel. In this case, we're going to use the iGel number 4. It's generally for your patients around 100 pounds. We would have the airway open. We insert the iGel past the tongue directly to form a seal over the airway. There's no reason to inflate the cuff. We can put the bag mask on, and we see chest rise. Notice the patient doesn't even need to be all the way supine. We can have them in our 45-degree position and still be able to intubate effectively.